So hi, welcome today. We've got an absolute cracker of a case today. So as the thumbnail and the title of the video today is, we're talking about doing a warm vertical technique in an upper molar. And I must be honest, I don't often do the warm vertical technique in upper molars just because it's so technique sensitive. So this video today is going to skip past a lot of the shaping protocol that I'm used to putting up here, and we're going to sort of focus mainly on this novel obturation technique. It will have a few other little things as well. We find a huge pulp stone, but overall, if you're not too sure what I mean by a warm vertical technique, well, that is essentially where traditionally when you're doing your obturation, you are using like a GP cone, and you're placing it in the canal, and then you're either using a bioceramic to fill the space all around it, or using accessory cones. With the warm vertical technique, essentially what you're doing is you're placing a GP point, and then you're using a heated plugger to burn off a lot of the excess GP up to about 5 millimeters away from the apex, and then you're condensing it down, and that leaves like a plug at the apical end, and then you're going to use warm gutta perca to backfill or fill the whole length of the space. And the reason why I've used this technique in this case is because the palatal canal is very, very wide. And I did put up a video quite recently when I had quite a large palatal canal, and I used a bioceramic backfill technique, and I had a lot of comments in the comment section below saying, what about warm vertical? So just for completeness, I decided to do the warm vertical technique in this case, just as a learning experience. So let's get on with the case. So we've got an upper left 6 here, and this tooth has been previously accessed by me, and the patient was in pain, so I dressed the tooth with Ledimix and a cotton wool pledget, and also some like a eugenol based filling material over the top. And when we look inside the cavity here, we can see there's a huge pulp stone. And what I want to do is I want to try and remove this pulp stone in one, mainly just for quickness, but also I don't want any tiny little fragments dropping down any of the large canals here, which can be difficult to remove. And what I'm using here is ultrasonic tips, just to try and undermine this huge pulp stone. And it transpires that really it's just too big. So what I need to do is just sort of gently sort of wear away this with a broader shaped ultrasonic tip, and this is kind of like a torpedo shaped, and rather than dislodging the whole thing and let it all fall out, I'm just going to just sort of grind it away. And as you can see now, the pulp stone's gone, and you can see 3 obvious canal spaces. You've got a mesiobuccal, you've got a distal buccal, and then you've got a very, very large palatal canal. And if you see a lot of my videos, you know that I like to go straight for the palatal because it's an easy bit of low-hanging fruit, so you can get to working length quite easily, and you can shape it, and then that's what's one canal boxed off, and then psychologically then you feel like you're on your way. And when we take a working length of this, we can see the 0 reading is 21 millimeters, and we're going to go straight for our master shaping file, okay, our final shaping file. And in this case, I'm using a HyFlex 25 variable, and we're going to shape it to 20.5, so it's 0.5 millimeters away from the working length. And I just felt like there's a lot of debris in this canal, so what I'm going to do now is rather than right at the end I activate my irrigant, I'm going to really activate the irrigant at this point, because I know if I get rid of all the debris, when I am shaping the DB and the MB, I'm always going to keep irrigating the palatal, and that's going to help me clean the palatal over the whole course of the appointment. So we irrigate and we activate, and you can just see all this kind of debris that's sort of coming out of this canal. That's a nice kind of feeling there. So essentially, it's the same shaping protocol for the MB and the DB, but in this case, the MB and the DB is quite narrow. So I'm going to use a glide path file. So I'm going to use a size 15 HyFlex glide path file. If you're not using glide path files, use them. They're absolutely fantastic. They just save lots and lots and lots of time. And as you can see now, all 3 canals are shaped, and I'm going to look for the MB2. And I'm just going to use the same ultrasonic, endo ultrasonic tip here. This is a sort of broad torpedo shape, just to remove the denting shelf around where the MB2 might be located. And I'm just going to sort of have a little look with a size 10K file, but I don't think that this tooth has any obvious MB2 canal. There's no kind of developmental lines, so there's no obvious kind of even a small orifice. So I am confident that this hasn't got an MB2. So once we know that we've shaped the canal, I'm going to go for a cone fit radiograph, and here I'm just going to place the cone in the palatal. Again, we're fitting it 0.5 millimeters away from the 0 reading find on the apex locator. We're feeling for tug back, and when we look at the end, it's a little bit stubbed. That could be where I've been pushing it a bit too hard, or it could be just where the portal of exit is just sort of a 90-degree angle. But overall, I'm quite happy, and I'm going to just snip off the end. Again, I like to snip off the end because when you go for the cone fit radiograph, sometimes if you've got this sort of excess GP flapping around, it can sort of pull it out, and you have to take another X-ray. And then again, we're going to do the MB cone fit, and again, the working length on the MB, the 0 reading is 20. I'm going to fit the cone to 19.5. Again, that's really important. You're always going to chop off 0.5 millimeters from your working length just to allow for the apical constriction. And again, we're going to snip off here. And then finally, we're going to do the DB cone fit. So the 0 reading is 21.5, so we're going to obviously clip it to 21. And it transpires that DB doesn't go to length, which is really annoying because you've got all the other GP points in there. And essentially, it's at this point you think to yourself, well, what do we do? Do we just fit it length and we just obturate? Never do that. I mean, it sounds blindly obvious, but if you do that, obviously, then you're going to be short on the DB. That's going to leave a void where bacteria can proliferate, and then obviously you're going to get a failure. So what I always do is I just pull all the GP cones out, reshape it, and now the DB cone goes nicely to length. So it's always really important that you do a good job and take pride in it. Okay, don't just fit it in there and think, oh, it'll be all right on the night, because that isn't great for the patient. But I understand that is that can be tempting. And then when we look at the cone fit radiograph, again, it looks really nice. All the cones are to length, and you can kind of see where the cones are following the natural sort of progression, or the sort of the smoothness of where the root goes. And I'm really, really, really happy with this cone fit radiograph. It's at this point now where we're going to do our final irrigation protocol, and someone asked me about my final irrigation protocol, and that is essentially using sodium hypochlorite activated, 70% EDTA activated, and then I do a final wash with sodium hypochlorite. Some people don't like to use that final wash, but I think once you've used the EDTA and you've opened up all them tubules, you want to get some irrigants in all them tubules and kill all that bacteria. And as you can see here, it looks really, really nice and clean. So you've obviously got to dry the canals. That's really, really important. We're just going to use these matched cone paper points, and then we're ready to gauge the palatal canal with this Mach 2 plugger. So as mentioned before, with the warm vertical technique, you're going to try and get at least a 5mm plug at the end of any root canal. And the 5mm is really, really significant because if you don't know, the anatomy of the root canal is very, very wide near the coronal or near the crown, and as it reaches the end, it can split off into many kind of lateral canals, and it's thought that the last 5mm of the root canal is the most complex. So what you want to ensure is that you've got a nice strong well condensed plug right at the end of this root. So when you come to burn away the excess amount, you're going to want to make sure that you're not pushing your instruments past that 5mm mark. So what I'm doing with this Mach 2 plugger is I am fitting it around 5 or 6mm away from the working length, which is about 15. So you can see here where we're measuring it, where we're at that 15 mark, and it's just a kind of a roundabout measurement. I wouldn't worry about it too much. Okay, this is kind of just a sort of a nice kind of sort of marker for you to use. And then you're going to coat your GP with a resin base sealer. You can't use bioceramic in this case. And you're going to fit the cone to length. Okay, you can't use a bioceramic with heat because the bioceramic doesn't work. Okay, it desiccates the dentin, so there's no water for it to set, and it also makes the bioceramic go a bit funny. And then same with the Mach 2 plugger, we're going to measure the heated plugger to 15mm. We're just going to very, very gently remove a little bit of the excess, and then you are going to get this heated plugger. You're going to activate it. You're going to push it down till you get to this sort of mark, the 15mm mark. You're going to hold it there for 10 seconds. You're going to push down apically. You're going to activate the heater, and then you're going to pull it out. And unfortunately, as we twist and pull here, you can see that this is one of the main problems with using the warm vertical technique, is that when you use the heated plugger, you can pull the whole GP point out. And this is probably one of the reasons why a lot of dentists are reluctant to do this technique, because it can be very, very technique sensitive. Now in this case, I've apically gauged this palatal canal, so I know that I can just pop that straight back in. I've got lots of magnification, so I can see really, really well. And I'm just going to pop it in with the heater plugger, and then condense it down with my Mach 2 plugger. And it's at this point where I think to myself, well, I've pulled this out. I've got no marker at all to work out if this is at the right length or not. So I personally, and people might disagree with this, like to take another cone fit radiograph, and you can see here the plug is at the apical end. It's got a nice kind of length to it. It looks really nice, really well condensed, and we're ready to backfill this. Again, a bit controversial. Some people might like to live on the seat of their pants and just plug this in and backfill it, but me, I like to make sure that this is fitted correctly. So I'm going to use the backfill here. I've got a B and L backfill unit. The great thing about this B and L is that you can use these kind of little pellets of GP rather than using these disposable, more expensive kind of cartridges. And because I can see the plug with direct vision, I am quite happy to backfill this all the way. A lot of the time what you can do is you can backfill a little bit of the heated GP, condense it a little bit, do a little bit more, condense it a little bit more. Takes a bit more time, but gives you a bit more control. But I think in this case, the canal was so wide, and I had direct vision with the microscope. I was happy just to backfill it. And once I've started to condense this with my Mach 2 plug, I can see that there's probably a little bit too much GP in the coronal aspect of this. So I'm just going to use a heated plugger just to remove the excess. And the great thing about this heated plugger is you don't have to sort of push down. You just push the heated plugger near the GP, activate it, and then it kind of heats the sort of GP around the heated plugger. And then if you just sort of touch the GP, it will pull a little bit of it out. And if you do this until you're happy, and really what the whole point of me trying to remove the GP is so I can create like a kind of a well where I can put my GIC, so that's going to seal off the orifice there, and that's really the whole point. I don't want it sort of level with the cavity floor, because then I can't sort of put my sort of like your GIC in there. So if you get a leaking coronal filling, having a bit of GI over the canal orifice is like a kind of second line of defense against leaking of the GP. Now we're ready to obturate the mesobuccal. Notice there is a distinct difference between the amount of sealer that I am putting on my warm vertical technique and for my single cone technique. And when I talk about single cone, what I mean is that I am going to fit this GP to length with lots and lots of sealer, and then almost all of the GP cone is going to remain inside the canal. So I'm not going to pull out you know, the vast majority of this with the warm technique. If you use lots and lots of sealer with the warm vertical technique, I'm telling you now what will happen is you will extrude a significant amount of sealer out the end. So you've got to be really, really careful. And again, this is another problem with this warm vertical technique. Really, really difficult to get, you know, the right balance between enough sealer so it fills all the kind of nooks and crannies of the tooth, but also that it doesn't come out the end. Again, a lot of people sometimes like to double dip, so they like to put the GP in and like to sort of pump it up and down. Again, I think that leads to extrusion. So essentially what I like to do is just to fit the cone to length and very, very sort of slowly push it until where we've snipped it off is level with the sort of the mark and where we know where we've done the working length. And then again, we just use the heated plugger just to heat off the end, get rid of the excess, and then using a Mach 2 plugger. And again, if you've seen lots of my videos, I like to push down quite firmly with a Mach 2 plugger, and then I use my other finger to really, really push down. And what that does is it condenses the GP and all the sealer into into the root canal proper. Don't be scared in doing that. I think when I was newly qualified, I was a bit scared about sort of pushing down hard, but there's nothing wrong with giving it a good old push down. And then we're ready for the DB. Remember, not lots and lots of sealer. Give it a good old coat, push it down nice and gently to length, get your heated plugger, just take away the excess, and then burn it off, and it looks really, really, really nice. So once you finish your obturation, the resin sealer, a lot of it's going to be sort of collecting in the cavity, and if you've ever used resin sealer before, you can't just wash it out nice and easy. So what I'm using now is some isopropyl alcohol just to dissolve the sealer. So I get like a big dollop of it on the end of a micro brush, and I just introduce it into the canal and just give it a good old sort of brush around, and that dissolves the sealer, and then you just wash it out all nicely. And as you can see here, everything just looks really, really nice, all clean. The GP is at the sort of coronal entrance to the root canals, and it looks really, really nice. And this is ready now for our our core filling. So as I mentioned before, I use a light cure GIC just to seal over the ends of the canal orifices, and then I use this kind of bulk fill SDR composite to fill it up. And we look at the X-ray, and this is just absolutely fantastic. Everything's to length, everything's filled, it looks gorgeous, okay? And again, I say this once, say 1,000 times, this is why I come to work for these types of root canals. This is a really, really nice, satisfying root canal to carry out. So I'm very, very happy with this, and I'm very, very happy to showcase this to everybody. So if you have any comments or criticisms about today's case, I urge you, I implore you to write in the comment section below, okay? It's really, really nice to get kind of, oh, thank you for this case, it looks really, really nice. But you know what I prefer? I like discussion, and I like debate. So if you think you would have done something different, if you think that, what I did was wrong, a certain case, put it in the comment section below, and let's have a really good debate about it. If you have any questions, again, if you're not too sure about a certain case, you pop it in the comment section below, and we'll try and answer all your questions as best we can. We also have a membership program. If you go to the home page of the channel, the membership program, of course, it helps support the channel, but there's early access to content, and also if you ask a question in the comment section below, I will reply to you personally with a video short. Overall, great case. Thanks for watching, and I will see you next week.